Hey there, ACCRACers. I want to tell you about a CME conference that I will be speaking at in the new year from February 28th to March 7th, 2026. It is an amazing conference. It is the Holiday Seminars Conference in Maui at the Hyatt Regency Maui Resort and Spa. I have been there before. I've spoken at this before, and it is incredible. The family, the Smith family that puts this on, they really do an incredible job. It's going to be some amazing speakers. It's a beautiful hotel and an opportunity to really enjoy Hawaii and Maui, and especially at a time when Maui is trying to recover from the wildfires. They're really going all out to try to make the tourist experience an amazing one. So I think this is a great year to come, and the conference is going to be incredible. You're going to hear from amazing speakers who are going to go over really, really high-yield topics. I highly, highly recommend signing up for this. You can go to holidayseminars.com and click on the Maui link, and you can register there. You can use CME money. It is going to be amazing. So I hope I will get a chance to see you there. It'll be a ton of fun. Hello and welcome back to ACCRAC. I'm Jed Wolpaw, and we are back with another keyword episode. I am thrilled to have with me, as always, Dr. Tym Kajstura, who is going to take us through actually the kind of miscellaneous section of the outline. He's going to tell us what that means and about that, but we're going to take you through this stuff that actually appears on exams quite a lot, but doesn't fall under any one given category. And so let's get to it. Tym, welcome back to the show.
Thank you again, as always, for having me. You're totally right. So we're doing special problems or issues in anesthesia today. And today is interesting because we're covering all of part D of the basic topics outline. So part A is huge. It's all of basic science. B is huge. It's all of clinical science, which is procedures and methods and techniques. And C is all of organ-based, basic and clinical sciences. And then there's this D of miscellaneous stuff, like you said. It covers 1, physician impairment or disability. It covers 2, ethics, practice management and medical legal issues. And there's a whole subset in there. We'll cover all of that. And I was looking at it, and actually there's also a corresponding section in advanced topics as well called Part E. It's special problems or issues in anesthesiology. Same name. It looks pretty similar. It has electroconvulsive therapy in it, organ donation, radiologic procedures, and anesthesia in locations outside of our operating rooms, and then the big ethics, practice management, and medical legal issues that the basic does. And also patient safety and quality improvement. And that's a lot to cover. ECT we've already covered in a different keyword episode. There are 2 ACCRAC episodes on organ donation. There's an episode on non-operating room anesthesia. So I don't think we need to rehash all of that stuff. We'll cover all of the basic outline part D and add in the corresponding topics in the advance to sort of round out that stuff so we don't have to come back to it. And all we'll have left that we'll tack in at some future point is quality improvement from part E. And again, you sort of alluded to this, as is often the case here, we can't cover everything in these topics. And it's actually a hard topic. I looked at the textbooks, and there aren't chapters sort of devoted in Miller or in Morgan McHale that cover this and say, this is what you need to know. It really is a little bit of a grab bag area. So my goal is to make sure we have a good grasp of the foundational basics and highlight the things that seem to get tested the most. And I'm going to throw in one other quick plug here. If people listening to this have requests, have ideas of what we should cover on the keyword episodes, feel like we've missed something, send us an email. I am happy to key up whatever people want to listen to next.
Sounds great.
Anything you want to add to that before we sort of dive into our initial concepts?
No, I think that's great. And I love the reach out. People can use the ACCRAC podcast at gmail.com or also ACCRAC at ACCRAC.com to send in emails if there's a keyword topic that you want to see covered.
Okay, so we'll split today broadly into 4 topics. We'll talk about licensure, credentialing, certification, sort of that stuff. Second, we'll talk about physician impairment and malpractice. I'll tell you why I lumped those together. And then 3, ethics, and 4, patient safety. So first up is licensure, credentialing, and certification. And what the ABA wants to make sure you understand here is how you get certified, how you maintain that certification, and the differences between all of those terms, certification, licensure, and credentials. So key concept 1, licensure. That is the recognition that you've met the baseline requirements necessary to practice a profession, in our case medicine. In the US, and I realize there are some international listeners here, and I apologize that a lot of this stuff is US specific, this will typically require having graduated from a medical school and completing the USMLE step exams, and is a state specific process. So you get licensed in different states. Key concept 2, certification in this context in medicine is meeting a national board requirement for some level beyond that basic licensure to practice medicine. An incredibly applicable example is how these keyword episodes are aimed at helping us pass the required written examinations and certification as an anesthesiologist by the American Board of Anesthesiologists. The American Board of Anesthesiologists also has subspecialty certifications that you can go for as well. All of those are above just your license. Key concept 3, credentialing and privileging are hospital and employer-driven process. Credentialing usually happens when you initiate employment. It's the process by which an employer confirms that you have the correct license. Credentialing, if there's any experience they require above that. And then privileging is related, but more specifically, it relates to an employee being given permission to perform certain clinical activities at their place of employment. So you could theoretically be certified to do some cases that your hospital hasn't given you privileges to do.
Yeah.
Anything you want to add about that? Yeah, go ahead, Jared.
No, I mean, I think this stuff is, it certainly may come up on exams, but also it's just good to know for in general. And I'm always amazed that people don't necessarily know this stuff. For example, you do not have to complete a residency to get licensed. You can complete, I think most states do require 1 year. So you can do for example, an intern year and then get a license and practice medicine. In theory, you could you could hang a shingle in your front door and say, I do neurosurgery here. And if someone wanted to come to you to receive neurosurgery, you could do it in theory. So you're not applying for credentialing or privileges since you have your own house and you're running a clinic. I don't know about getting the machines and things that would be needed, but the point is that you can get a license to practice medicine without completing a residency. That is different than getting board certified, as Tim said, and getting privileges and credentialing. And most hospitals, in order to credential you and give you privileges, will require that you be board certified, not just licensed. But again, that's up to the hospital.
And just because I think this will come up at some point, I'll mention that actually not just board certification, but at least be board eligible. So if you're early out of residency and are still on the process that you may end up certified and just haven't completed those exams yet, that's often enough as long as you haven't lost your eligibility for some reason.
Yep, you're totally right. Sorry, I misspoke, and you are correct. It should be board eligible or board certified. Exactly.
All right, let's do some questions. Number 1, a medical doctor successfully graduates from an accredited anesthesiology residency and applies for a new job at a community hospital. Which of the following can wait until after they start working clinically? A, gaining certification in anesthesiology, B, being credentialed by their employer, or C, obtaining a state medical license.
Great. And so hopefully what we just went over helps answer this, but you probably will not be board certified in anesthesiology when you first get a job. You will be board eligible, meaning you are in the process of trying to get it, but you don't have to have it yet. And so that would make A the correct answer. But you do, of course, in order to start working clinically, need to be credentialed at your hospital, and you will probably not be able to get credentialed or be allowed to practice in a state without a state license.
Perfect. Question 2. An anesthesiologist who has been practicing in their current setting learns a new procedure at an anesthesiology conference and incorporates it into their practice. After having it initially flagged by the billing department, they are told they are not allowed to perform this procedure. This is most likely related to their A, licensure, B, profession, or C, privileges.
Right. So this gets down to what you were saying, Tim, that the specific procedures you are allowed to do at a hospital are your privileges. And so you can't just decide to do a new procedure. You have to be privileged to do it. And so privileges is the correct answer here. And your licensure does not dictate you can do this, you can't do that, right? Your licensure allows you to practice medicine, but the hospital you work at has to decide which things you are allowed to practice at that hospital.
Yeah. And that last answer, profession, I don't know exactly what they're getting at, but if it's, you're practicing anesthesia, you learned something at an anesthesia conference, it's probably not that you're trying to suddenly do some kind of neurosurgery. So it's probably not related to your profession.
Right. Although I will say that's a little tricky because you might think, oh yeah, like I can't come and bring something back that isn't in my specialty, but actually you could get privileged to do something that isn't traditionally done by your specialty. So if you are an anesthesiologist and you go and you learn how to do percutaneous tracheostomies, which is more typical for someone with critical care training, but not so much for just people who just do anesthesia. But you could apply for privileges. And if your hospital was willing to privilege you to do that, you could do it.
Absolutely. All right. Another set of questions on certification that are common on the ABA exams deal with maintenance of certification. And unfortunately, these questions tend to test knowledge that simply just must be memorized. It's just the rules of maintenance of certification that the ABA has. And you don't really come across this until you actually start working on maintaining your certification, which by definition is after you've taken all of these exams and passed them. So they just sort of force you to learn this stuff a little bit early. Key concept 4, I've tried to just give you the numbers and what you need to know and what I've seen show up on exams. And the current maintenance of certification program from the ABA is the MOCA 2.0 program. I think this applies to everyone 2016 or after, somewhere around there. And the cycle is a 10-year cycle, though some requirements need to be done at more specific timeframes, and there are 4 parts. 1, you must hold an active unrestricted medical license. 2, you must earn 250 Category 1 CME credits, 20 of which must be related to patient safety. 3, you must participate in MOCA Minute, answering 120 questions a year and the released 30 questions per quarter. And 4, you must earn 50 quality improvement points, 25 in the first 5 years and 25 in the second 5 years, and complete an attestation towards the end of that 10 years. And I apologize. Those are just numbers you're going to have to learn, and they do come up pretty regularly on examinations.
And Tim, I'll just make one small thing, which is that it changed actually recently, so that it's now a 5-year, not a 10-year cycle in anesthesiology. And I think that was mandated by across all boards and all specialties, but for sure it's true in anesthesia. So now it doesn't really matter. All it means is that instead of 5 in the first year, 5 years, 25 in the first 5 years, 25 in the second 5 years, it's just 25 in 5 years, and then it resets, which essentially makes it the exact same thing. But it is now a 5-year cycle, and then it restarts.
All right. Perfect. Shows you even I, who am starting my maintenance right now, is not quite clear on the numbers. So
exactly.
All right. Question 3, which of the following qualifies toward the quality improvement portion of the current ABA maintenance of certification guidelines? A, attending a mortality and morbidity conference. B, presenting at a mortality and morbidity conference. Or C, completing 30 MOCA Minute questions a quarter.
Yeah, and so what you'll see when you do get board certified is that there are a list of things that count toward the quality improvement portion, and attending an M&M conference does not, but presenting does count for part of it. And so that's the answer here. And while you do need to do 30 MOCA Minute questions per quarter in order to maintain your board certification, that does not count toward the quality improvement part. Other things that count are attending simulations around that have to do with quality improvement, writing up cases, leading a quality improvement project at your institution, and things like that.
Perfect. And 4, which of the following is required to be compliant with the ABA's Maintenance of Certification 2.0 program? A, completing 120 MOCA Minute questions per quarter. B, having an active driver's license at the time of recertification. And C, paying an annual MOCA program fee.
Right. So tricky maybe because you think A, but it's 30 a quarter, not 120 per quarter. So A is incorrect. Having an active driver's license, everyone in New York just panicked, but no, you do not need a driver's license to do any of this, but you do need to pay an annual MOCA program fee.
Yeah, and you do need an active medical license, but
Correct.
not the driver's license. All right. In the next session, I want to talk about physician impairment and malpractice. And the reason this kind of follows naturally is that the questions that they ask often relate to what needs to be reported regarding malpractice and impairment and how that impacts licensure and or recertification. So we just talked about all the rules for how to get certified and maintain that. And then these are some things that could potentially cause a challenge in those. Key concept 5. To establish a medical malpractice lawsuit, a plaintiff must prove 4 elements, and I think these are worth knowing. 1 is causation. Did an act or an omission cause the poor outcome? 2, duty to the patient. Was the defendant, in our case it would probably be us, the anesthesiologist, are we responsible for the patient's care? 3, negligence or breach of duty. Was the standard of care not met? And 4, are there damages? Does a malpractice rise to the level that money should be given to the plaintiff? So whenever I ask them about malpractice, they talk about, if this is malpractice or not. Think about whether those things are true. And then key concept 6, any malpractice payment must be reported to the National Practitioner Data Bank, even if the case is settled out of court. Additionally, the following are also reportable events: adverse clinical privilege actions, professional society actions, exclusions from federal or state healthcare programs, licensure and certification actions, healthcare-related criminal or civil convictions or judgments, and negative actions from peer review or private accreditation organizations. And I don't want you to memorize all that. I'm glad you just heard it. Thank you for that. But for test-taking purposes, just assume that if some entity within the licensing, certification, or credentialing pipeline or a court took action against you or an anesthesiologist in some way, it's reportable. Also note that you have 60 days to notify the ABA if a restriction has been placed on your license. And that's something that generally the reportable events will be reported by someone else. You're required to tell the ABA if someone has restricted your license. Okay, key concept 7, physician impairment in anesthesiologists can occur secondary to substance use disorder, commonly tested, or a plethora of other issues, including depression, financial strain, medical disorders, personal relationships, etc. Substance use, including alcohol in anesthesiologists, occurs at the same rate as the general public, about 10 to 20%, and it's about 1 to 2% for drugs other than alcohol in anesthesiologists, of which opioids are the most commonly misused. The death rate for anesthesiologists with a substance use disorder is about 10 to 15%. And it's notable that the risk of death for anesthesiologists who had a substance use disorder during training is much higher than those who did not later on in their careers. Those are all numbers of things that I've seen tested before, and that's why I've given some of those numbers to those facts.
Great. Yeah, I agree. This stuff, especially the substance impairment stuff, comes up a lot on tests.
Okay. So let's do a few practice questions. Number 5, an anesthesiologist in an academic practice is concerned their colleague's performance is impaired secondary to a substance use disorder. What is the best approach? A, privately ask them if they are abusing opioids. B, tell a department leader what their concerns are. Or C, ignore this as impairment can occur due to non-substance use issues.
Yeah, so I mean, hopefully C is something you can cross out, and then you're trying to decide between A and B. And while you might be tempted to think like, look, I don't want to get them in trouble, maybe I should talk to them individually, the right answer here is to tell a departmental leader about your concerns. And that is going to be the answer on these types of questions.
Yeah, and I'm curious. I think there's a few reasons why that's the best answer. Why do you think that's the best answer, Jed?
So I think there's a few reasons. One is that you want this handled in a professional way by people who are expert and trained in handling this, so that the person doesn't feel threatened, they feel supported, and that they can be, if it is in fact a justified concern and they are appearing to be impaired at work, they can be tested appropriately and get the support they need. If you go, ask them, first of all, the chances are they're going to say no, even if they are. It may spook them. It may make them feel panicked. It may make them do something rash. It may make them, feel like they need to, go hide all of the things that they have been doing in a way that would make it a lot harder to find out that they're doing it and then get them the help they need.
Yeah. And I think I'm right there with you. I'm not sure that in any of the research I did for this, I sort of found a slam dunk answer of why that's the best course of action. But I think leaving it in the hands of people that have the most experience in doing this, have the knowledge in how to approach these things is going to lead to the best outcome for anyone if they are in any kind of danger or need any kind of support.
For sure.
Question 6. You are named in a malpractice lawsuit after a patient experienced an extended hospitalization secondary to a complication from a radial arterial line. You and your hospital system decide to settle out of court. The following is now required. A. This must be reported to the National Practitioner Data Bank. B. You must inform the American Board of Anesthesiology within 60 days. Or C. You must reapply for arterial line placement privileges.
Yeah, so the answer here is A. As you said in your overview, if you have a finding against you or you settle a lawsuit against you, you have to report that to the National Practitioner Data Bank. Unless an action was, a restriction was placed on your license, you do not have to report it at all to the board. And unless your hospital decided to rescind your privileges for arterial line placement, then you would not have to reapply for privileges.
Perfect. 7. You are a resident in an anesthesiology program. You are surprised when one of your colleagues announces that they are taking leave of absence to obtain treatment for a substance use disorder. You look up the statistics and find that compared to the general population, substance use in anesthesiologists is A, much less common than the general population, B, much more common than the general population, or C, about as common as in the general population.
Yeah, and I think maybe somewhat surprisingly, for people, the answer, as you went over earlier, is about as common as in the general population. So it's a big problem because one is too many. But also remember, the general population includes a huge number of people. There are going to be lots of people with substance use disorder, et cetera, whereas we're taking people who are very successful professionally and then saying that actually the rate is about the same, which means, quite disturbingly a large number. So we want to be really aware of this, but the number is about as common. The percent is about as common.
Yeah.
Stay with us. We'll be right back. Hey folks, whether you're caring for patients in the OR or managing unstable airways in the ICU, you know it's the unexpected, high-stakes airways that stay with you. The ones where decision-making, technique, and team communication make all the difference. And if you want to be prepared for these situations, I highly recommend you check out the Difficult Airway Course, a hands-on airway course designed for clinicians managing high-risk airways. The Difficult Airway Course offers accredited hands-on training with specialty-specific courses designed for anesthesia, critical care, and emergency medicine. The focus is on practical, immediately applicable skills including airway assessment and planning, video laryngoscopy, fiber optic techniques, peri-intubation optimization, and managing failed or rapidly evolving airways. What sets the course apart is the format: small group hands-on workshops and realistic code airway scenarios led by a world-class faculty. Courses are offered 4 times this year, in March and November in San Diego, May in Boston, and September in Atlanta. Space is limited, so groups stay small, with plenty of opportunity for questions and conversations with faculty. So if you're looking to sharpen your airway skills, whether you're early in your practice or many years in, visit theairwaysite.com to find your course and register. As a bonus, our listeners can use code ACCRAC26 to save $100 on registration. That's theairwaysite.com and use code ACCRAC26. Hey folks, it's the new year and we're all busy trying to live up to our New Year's goals with no time to cook. That's why I love Factor. Factor makes it easy with fully prepared meals designed by dietitians and crafted by chefs, so you can eat well without the shopping or cooking. My kids think Factor tastes like restaurant food, and it really does. Even my 2 younger daughters, who are very picky eaters, are loving every meal we get from Factor. Some favorites are the shredded chicken taco bowl and the smoky Gouda macaroni with shredded beef. We love the taste, and we love how healthy it is, with quality, functional ingredients including lean proteins, colorful veggies, whole food ingredients, and healthy fats. There's no refined sugars, no artificial sweeteners, no refined seed oils. With 100 rotating weekly meals and the new Muscle Pro collection to support strength and recovery, it's no wonder people love it. It's not just healthy, but super fast and so delicious. I wouldn't have believed it until I tried it, and now I can't get enough. Get Factor if you want all the flavor and none of the fuss. Head to factormeals.com/ACCRAC50off and use code ACCRAC50off to get 50% off your first Factor box plus free breakfast for 1 year. The offer is only valid for new Factor customers with code and qualifying auto-renewing subscription purchase. Make healthier eating easy with Factor. Hey folks, this episode is sponsored by BetterHelp. The new year doesn't require a new you, maybe just a less burdened you. Therapy can help all of us more easily identify what is holding us back by offering an unbiased perspective to better understand our relationships, motivations, and emotions. I've spent a lot of time learning to worry less about the future and enjoy the here and now, and it's made a big difference for me. With over 30,000 therapists, BetterHelp is one of the world's largest online therapy platforms. They've served over 5 million people globally. And it works, with an average rating of 4.9 out of 5 for a live session based on over 1.7 million client reviews. BetterHelp does the initial matching work for you, so you can focus on your therapy goals. And with 12 plus years of experience, they typically get it right the first time. If you aren't happy with your match, switch to a different therapist at any time from their tailored recs. BetterHelp makes it easy to get matched online with a qualified therapist. Sign up and get 10% off at BetterHelp.com. That's BetterHelp.com. Hey, ACCRACers, we are thrilled to have as an all-star returning sponsor the one and only TrueLearn Smart Banks. I've used TrueLearn for my residents for years, and it is hands down the best smart bank out there. The questions are excellent, and the answers have clear explanations that break down why each choice is correct or incorrect. And now you can create flashcards, which are a key tool for high-quality studying and maximizing test performance. The education research is clear that spaced repetition with these kind of tools is the best way to learn and retain information. We use their ITE, basic and advanced smart banks for our residents, each with 1,000+ questions, realistic visuals, and graphs, and even a calculator that mimics what you have on the exam. Our residents love it and get great results. TrueLearn even has a CME smart bank where you can get AMA, PRA, Category 1 credits after you finish training, and an adult cardiac anesthesiology smart bank as well. Go to TrueLearn.com and use code ACCRAC to get $25 off residency exams, USMLE, and Comlex smart bank subscriptions of 90 days or longer, and up to 20% off other healthcare exam subscriptions. We rely on TrueLearn for our test prep, and I recommend you do the same. TrueLearn.com and use code ACCRAC. Hey there, ACCRACers. You know what can make a real difference in your quality of life at work? Comfortable scrubs. And not just any scrubs, but FIGS scrubs. They're made for awesome humans and I think can truly make a difference for healthcare workers by keeping our needs in mind. Plus, it's a new year, a new you, or at least a new uniform. If you're in healthcare, it's the perfect time to upgrade your scrubs to FIGS. They're lightweight, durable, super functional, and ridiculously soft. I love my FIGS, and let me tell you, my wife, a pediatrician, loves her so much, it's all she wears to work. Ever since COVID, she's all FIGS all the time. It doesn't matter if you're a dentist, a nurse practitioner, a medical student, CRNA, SRNA, or an anesthesiologist like me. Investing in a couple of pairs of FIGS is totally worth it. With new limited edition colors and styles, FIGS is putting the fresh in uniform refresh. Scrubs, outerwear, footwear, accessories, and more. You'll be looking sharp, feeling good, and ready to take on anything. 2026 is here, so let's do this. Take 15% off your first order at wearfigs.com with the code FIGSRX. That's wearfigs.com, code FIGSRX. All right, and we're back.
And just worth hammering that point home, which is why that question is here again, that you would think that secondary to all of the things we hear about, the ease of access to medications that can be abused, the stress of being an anesthesiologist, that you'd think that the rate is higher. It is not, at least than the general population. Next up, ethics. And I know I'm being repetitive here, but again, we won't and couldn't possibly cover all of medical ethics here. I just want to refresh us on some of the foundational definitions and give a few examples of how these show up on the anesthesiology boards. Key concept 8, the 4 main principles of ethics. As a reminder, there's 1, autonomy, respect of an individual's right to make their own decisions. Beneficence, the obligation to act in a way that promotes good outcomes. 3, non-malfeasance, the obligation to avoid causing harm, the do no harm principle. And 4, justice, ensuring fairness in the distribution of resources and the treatment of individuals. And key concept 9, one of the ethical principles that get tested a lot is consent and what is informed consent. So I'll remind you that capacity is the ability to understand information and use it to make a decision and communicate that decision with others. And capacity can be specific to individual decisions. Consent is the voluntary agreement itself to a decision, such as to undergo a certain treatment or surgery. And consent is not permanent, and it can be revoked at any time. So just because someone did consent does not mean that they continue to consent to something. You want to dive right into questions?
Let's do it.
8. A 14-year-old child presents for an elective outpatient procedure. You arrive to the preoperative holding area and discuss the risk and benefits of anesthesia with the patient and their mother. Before proceeding with the case, you should get A, consent from the mother and consent from the child, B, consent from the mother and assent from the child, or C, assent from the mother and consent from the child.
Yeah, so I think this is so interesting because this concept of assent was not taught. It may have existed, but it wasn't taught when I was in medical school. And yet it is being now. And I know this because I'm an oral board examiner and I've had people use this term, the examinees, and I had to look it up because I had not heard it before. So it turns out that this is a thing. So you have to get consent, which is the legal requirement, from an adult. So it's either the patient who's an adult, or in this setting, because the patient is under 18, you need to get the mother or father or guardian's consent. In this case, it's the mother. So you need consent from the mother. But the ethical thing to do with a child who's old enough to give assent is to get assent. In other words, you want the child to agree that they want to have this procedure too, even though the legal consent comes from the guardian.
Yeah. And so in this question, it's pretty straightforward. Yeah. B, get consent from the mother and get assent from the child. I would be surprised if you start seeing the ethical gray areas of a legal guardian giving consent and you not having assent from the minor and then asking you what you should do. There's few answers that are correct when they just say call an ethics consult, but that would probably be one of them, depending on the urgency of the procedure. Yeah,
there's no way that would come up on written boards. I just cannot imagine. I think in theory it could come up in oral boards, but that would be something you would have to kind of think your way through. I don't think there are some wrong answers, right? I think the wrong answer would be to say we don't care what the kid thinks. But, again, talking it over, trying to get some understanding of what's going on, maybe bringing in the ethics team, deciding whether it's an emergent or urgent procedure or not, right? So lots of things that could play a role in your discussion if it was oral boards, but not going to happen. Too complex for a written board question.
Absolutely. Question 9. A patient is admitted to the intensive care unit from the floor after emergent intubation for acute hypercarbic respiratory failure. After reviewing the medical record, the intensivist notes that the patient received multiple intravenous boluses of opioids prior to respiratory failure from the first call provider due to reported 10 out of 10 pain. Which ethical principle did the first call provider most likely follow in ordering these medications? A, beneficence, B, non-malfeasance, or C, autonomy?
Yeah, so these, this comes up all the time, right? They want you to know these terms and what they mean. So this doctor was trying to do what he or she thought was going to help the patient the most, to do good for the patient. And that's beneficence. So that's the answer. Non-malfeasance would have been do no harm, which would have actually been the opposite, right? Which would be to say, well, I'm not going to give it because I'm afraid of the harm it might do. And autonomy would be to maybe give the patient a PCA, right? Give them some control over the dose of the medicine that they're getting.
Perfect. Question 10. You are asked by a colleague to consent an inpatient for general anesthesia for a procedure scheduled the next day. The patient does not know why they are in the hospital or what procedure they are going to have. They happen to be retired anesthesiologists, can recite back the risks and benefits of a general anesthetic you described, and agree to general anesthesia for the procedure. You should A, have them sign the anesthesia consent form, B, tell the primary team the patient lacks capacity to make medical decisions, or C, request an ethics consult.
Yeah, I actually think this one is a little tricky. So, what they're describing is a patient who clearly knows what anesthesia is, what the risks and benefits are, and can recite that back to you and discuss it. So they understand the risks and benefits of anesthesia, and they are willing to consent for anesthesia. They clearly cannot at this moment consent for surgery because they don't even know what surgery they are going to have. But I think what they're getting at here is that you can consent them for general anesthesia because they understand the risks and benefits of general anesthesia, and that does not mean they're consenting for surgery. And so you can do that. You can have them sign the consent form. The primary team, it's not that the patient lacks capacity, it's that they just don't know. So the primary team would have to, of course, have a discussion with them and explain the risks and benefits of the surgery they're having and make sure they can understand the surgery they're having and all that in order to consent for surgery. And you don't need an ethics consult here unless it were to happen maybe that you felt a patient did not have capacity to consent and the surgical team was insisting on consenting them, then you might need an ethics consult.
Yeah, and I think this is sort of splitting hairs, but importantly, to make sure that you understand, as uneasy as it is to have someone sign an anesthesia consent form and say they know how to consent for anesthesia and can consent for anesthesia when they don't even, they may not know why they're in the hospital. Capacity is a decision-specific thing. You can have capacity to consent for anesthesia, even if you don't have capacity to consent for something else like surgery. Okay. And lastly, we'll cover some of the most commonly tested patient safety topics. So this is the fourth of our 4 topics today. Key concept 10, while supportive, non-judgmental, voluntary patient safety reporting programs are encouraged and exist in most hospitals, the reporting of sentinel events to the Joint Commission is mandatory. Sentinel events include those that result in death, permanent harm, severe temporary harm, and intervention required to sustain life. Key concept 11, medication errors are a common source of adverse patient safety in anesthesia. Errors can include omission, giving the wrong medication, giving the medication through the wrong route, giving the wrong dose of a correct medication, misdocumentation, or an inadvertent bolus. I think by this, sort of the most common example is if you have a vasopressor infusion going and you give a medication you meant to give, but you flush in extra vasopressor, that's an inadvertent bolus. And the risk of medication error can be reduced through the use of pre-filled syringes, color coding of drug types, avoiding look-alike names or vials, barcode labeling, smart infusion pumps, and clinical decision support software. A lot of the questions in patient safety, I think, especially in anesthesiology, rightfully so, focus on medication errors, as they are some of the most common errors in our field. And then key concept 12, and our last key concept for the day. When medication errors or other unanticipated outcomes occur, these should be disclosed to the patient and family in a timely manner. Beyond the ethical requirement to do so, studies have found that disclosure of errors reduces the risk of litigation. Anything to add in terms of patient safety? Anything you see often that I haven't mentioned?
No, I think these are key. I guess I would say that the part about disclosure is really important. It's the first time you do this, it's really scary. You're going to be tempted not to do it. And you, as a trainee, I mean, you should obviously be doing this with an attending who can help you through it. But, you know, it is really important, and it does engender trust. If you go and you say, look, this is what happened. This was, you know, we're terribly sorry that this happened. And by the way, there are laws in most states that protect you. You cannot be sued and to be said you admitted to fault because you used the word I'm sorry. So it is okay to say I'm really sorry that this happened. You know, this is what happened. This is what we're doing about it. So, as you said, doing that actually will reduce the risk of litigation, and we want to disclose, and we want to be very clear about what we're doing to try to correct the problem.
Yeah, thanks for that. All right, a couple last questions, and we'll wrap up for the day. Question 11. An emergent abdominal case is starting in an operating room. During timeout, it is stated that the patient received metronidazole in the emergency department. The anesthesiologist in the room administers cefazolin before incision. The patient later develops a postoperative infection, which requires emergent reoperation, and it is discovered the likely cause was that the metronidazole was never administered. Which of the following is true regarding this medication error? A, it could have potentially been avoided with clinical decision support software. B, it does not need to be disclosed as the wrong medication was not given. And C, it does not need to be reported to the Joint Commission.
Right. So this is an error that led to significant patient harm. So it does need to be reported to the Joint Commission. It should be disclosed because, again, it was an error, and we should be open about that with the patient and family. And so the answer is going to be A, it could have potentially been avoided with clinical decision support software. And like many medical errors, the system could be better that might have prevented it, right? So we don't want to be necessarily saying, oh, this individual provider really screwed up. Any of us could have made this mistake. But if there had been a system which was able to make it clear if the medicine had or hadn't been given, if there was a requirement, for example, that the nurse scan the medication as it was being given, that wouldn't have happened. And then an alert would have popped up on the anesthesia provider screen saying, flagyl never given, then that might have prevented this. So while we do want to disclose this, and we do need to report it to the Joint Commission, that doesn't mean the provider who had this error is, somehow a bad provider. It means that the system should be improved so that this doesn't happen again.
Yeah, and thanks for highlighting that. I think I sort of briefly mentioned it, or sort of assume that it's understood in key concept 10 that the voluntary reporting systems should be supportive and non-judgmental. And in doing that, they should look at the systems issues that led to these errors being happening, rather than sort of figuring out who is to blame for them. And I guess one other thing we can add here is the idea of a root cause analysis, which is a investigation into a reported event, always looks to figure out what was the ultimate cause of something, not to give blame, but so that can be fixed, if you see those types of questions come up.
Great.
And then number 12, an anesthesiology resident is finishing an outpatient surgical procedure and proceeds to administer what they think is ondansetron. Shortly thereafter, the patient's heart rate increases and the resident notices the vial they thought was ondansetron was in fact atropine. The resident did not spot this mistake earlier because the two drug vials appear similar. Which of the following would be a cost-effective and appropriate method to help prevent this error in the future? A, the use of tall man lettering. B, the use of an electronic barcode labeler, or C, the use of a second person to check medications prior to administration?
Yeah. So first of all, I love this question because if anyone was at ASA, I did a live podcast episode there where we talked specifically about how the human brain can actually tell you that the vial you're looking at that says atropine, your brain may actually make it seem to your eyes like it says ondansetron, right? So it actually isn't sufficient to just say, oh, Tim, you made this mistake. You need to look more closely. Read closely, Tim. Just read closely and it won't happen. That actually is not a good solution because you may have actually picked up that vial and looked at it, but because the situation and the color of the vial and everything was telling your brain this is ondansetron, you may actually have seen ondansetron written there, which is crazy, but that's actually how the human brain works. So it isn't, I mean, it's a good idea. We should always read the labels, but we can't just say if you make a medication error, it's because you didn't read the label. Okay. And so changing the size of the lettering is not going to necessarily help in that situation. But the use of an electronic barcode labeler, right, where you scan the barcode and that pops up, right, so that you would see presumably, we don't actually have this, so I don't know how this would work. But presumably, this is going to cause a pop-up that's going to say atropine right on your screen or something, so that you would know exactly what you were giving, and maybe even an alert that would say, "Are you sure you want to give atropine to this patient whose heart rate is 80?" Right? And so that is a systems change, which could make a big difference. And the use of a second person to check medications, I mean, sure, that probably would help, but again, that's not cost-effective because now you're talking about having to pay another person to be there to do this. Or take a nurse away from what they're doing and just, delay things in the OR. So while that is possible and it would probably help, it's going to not be as cost effective as having an automatic way to do this.
Absolutely. And the tall-man lettering is absolutely cost effective and appropriate. It's just for sound-alike medications, which this isn't, right? This is a look-alike issue, not a sound-alike issue. The tall-man lettering is great for difference between ephedrine and epinephrine and things like that.
Great.
All right. That's all the key concepts I have today. Those are all the questions I have for today. Anything else we should talk about?
Fabulous. No, this is really high-yield stuff. Thank you, Tim. Let's turn to the portion of our show where we make random recommendations. Do you have something you'd recommend the audience check out for fun?
I do. I thought of this recommendation soon after we recorded our last podcast, and I realized that I think many people, myself included, just recommend the last thing that was sort of cool that came into their life. And I realized there's something that I use every single day that I absolutely love, helps me stay organized. And it's called Workflowy. It's a note-taking application. It's a website. It has a mobile app as well. And it is flexible. It's minimalist. It has a really simple design. And I use it to keep track of all of my projects, all of my daily to-do lists. I don't think I haven't looked at this, multiple times a day for probably a decade or more. So strong recommendation for Workflowy if you're looking for a new way to get and stay organized.
Awesome. How do you spell it?
Work like work and then FLOWY, like workflow Y.
Workflow with a Y on the end. All right. Awesome. Fabulous. I'm going to recommend a TV show. Wednesday is a great TV show on Netflix that's like the modern take on the Addams Family. But the second season we just finished, and so we enjoyed the first season, and the second season also was really entertaining. It's interesting. It's really well done. It's kind of a mix of a little humor, definitely murder mystery. It's incredibly well acted, and it's fun to watch. So I recommend you check out season 2 of Wednesday. All right. Tim, thanks so much for coming back on the show.
Thank you. I'll see you for the next one. And again, if anyone has any requests on what to cover on the next Keywords podcast, email ACCRAC@ACCRAC.com.
You got it. Or ACCRACpodcast@gmail.com.
Awesome.
All right.
Thank you so much, Ed.
See you soon. All right. Hopefully you got as much out of that as I did. That was really fantastic. Let us know what you thought. Go to the website, ACCRAC.com, where you can leave a comment. Others can learn from what you have to say. If you are a fan of the show, you can follow us. We're on Twitter. We are on Facebook. We are on Reddit. And we are on Instagram. I'm at Jay Wolpaw on Twitter, and we're at ACCRAC Podcast, and you can find us on all those other platforms as well. If you are a fan of the show, please consider going to Apple Podcasts or wherever you get your podcasts and leaving a comment and a rating. It really helps others find the show. If you'd like to support the making of the show, please consider going to patreon.com/ACCRAC. That's patreon.com/ACCRAC, where you can become a patron of the show. Even if it's just $1 or $2 that you pledge, it makes a big difference, and we really appreciate it. You can also make donations anytime by going to paypal.me/ACCRAC or looking up Jay Wolpaw on Venmo. Thank you so much to those who have already made donations and become patrons. We really appreciate it. Thanks, as always, to our fantastic ACCRAC crew. Sonia Amanat is our tech lead. Taylor Duggan, William Mao, and Rachel Furman are our production assistants and social media managers. Thanks so much for all you do. Our original ACCRAC music is by Dr. Dennis Quo. You can check out his website at studymusicproject.com. All right. That is it for today. For the ACCRAC Podcast, I'm Jed Wolpaw. Thanks for listening. Remember, what you're doing out there every day is really important and valued.